Well, what we tried to do was to try and make the presentation fun. And to try and get over the importance of clinical supervision. And part of that was engaging people across the organisation in a bit of a fun way to make sure that we can use that message to help promote clinical supervision, the value of reflection for the individual in terms of managing their own health and well-being, but also the value of reflection for service users and the experience of service users. When people, good evidence out there where people stand back, reflect, have clinical supervision. Then service users get a better experience. People will look at what they do and look at the way that they deliver their service and improve on it and improve as a result of looking back with some support from someone who's perhaps more experienced or from a different perspective. We want all care staff to have access to it, so we wanted to make that clear. We wanted to make sure that there was training for people to be supervisors and to increase that pool, have a list of supervisors so people could access it, and make sure that we prioritise time. Before we started, there was no system of assuring ourselves that people were having supervision. They might have been, they might not have been, so we wanted to set up a very easy electronic recording system so that people could record when they had their supervision. So we managers, leaders know when their teams are having it and where the gaps are, so that can make sure that people do get access to supervision. I think there's a number of issues. We recognised the value of clinical supervision from a patient perspective. I think there was a recognition that we didn't do it as well as we wanted. We couldn't demonstrate we wanted to do it as well as we wanted to, and certainly there were a number of lessons that we were learning from other visits from the CQC, for example, when they were visiting trusts, was clinical supervision isn't embedded, isn't systematic within an organisation. Like many organisations, like I think most organisations across the country, one of our biggest causes of absence from work, sickness absence from work, is stress-related illness, and we know that clinical supervision is a really important aspect of helping to reduce stress for staff. Reflection, being able to talk about the issues that they confront and to constructively move on from them so that they don't end up in that situation again. We know this is the right thing for our staff, we know this is the right thing for our service users, our patients, and therefore we really wanted to get to that sort of common goal and achievement. So lots of passion and lots of energy and lots of enthusiasm that people got the people who got involved. We recognised what we could do in 20 weeks was fairly limited. We've got a good structure now to move on, but actually now it's about embedding it, and I think the team always thought that was going to be the situation. We wouldn't get it to the perfect point, but we've now got a really good foundation, and it is really about making sure that we embed it properly.
We have had several reports from inspections from the CQC through the Mental Health Act visits that they do, and there were recurring themes that just happened over and over again. We're not filling out the right forms, or not reading out rights to patients, not signing care plans, and we thought that it would be a great way to stop all the recurring themes from happening that we've heard from the CQCs. We would have care plans, they would be in the records, but they wouldn't be signed, or it wouldn't be shared with a patient, and sometimes they didn't exist. The other thing that was happening more often than not is you'd have the report and then staff would come back and say, oh, but it's in the patient folder, but it wasn't filed in the right section. We thought, well, one way of going forward is try to address it through listening into action, to check what is stopping staff from doing what they know to be right. And because they're so simple anyway, it's just interesting that we didn't seem able to get it right. First thing we did, of course, was to ask people, why couldn't you, for example, why aren't rights being read to patients or consent being taken from patients? So one of the things we did was to look at records and how we can revise the forms to make it easy for people to, when they're admitting a patient, for example, just to go straight to the consent. So it's almost a reminder that they need to gain consent, record consent, and file it in the right place. We also revised some forms to make it simple. So people said, for example, that the leave of absence form, when people are detained, there were so many complexities around filling out the form. So we listened, redesigned the form and made it simpler, and it got to a point where people were just able to sign it very quickly with the patient rather than having to fill in a very long and complex document. The one thing as well that people often said was, well, that's not my job. So there wasn't a clear person who was responsible for keeping the record. So we have made it clear who is responsible for making sure that the records are in the right order and that we've got the right things where they should be. I think one of the important things was getting people of a like mind who were passionate about getting it right together. And again, people with expertise of actually being in the front line of recording, getting them together. We were able to get ideas together about how to make things work quickly. However, I think there's still challenges that we need to get in place to embed that culture. So I think it's a journey that we've started. However, I think there's still some work in making sure that now that people are doing it, it becomes a way of life and it's automatic.
We found that people moving between services, which we call transition because of largely age, but for sometimes other reasons as well, that doesn't go as smoothly as we'd like it to go. So, for example, when people are coming up to 18 and they transfer between our CAMS service and adult service, or when they're coming up to 65, although it's a bit wider in terms of some of the older people, that process can be a bit cumbersome. We wanted to make that as comfortable and as easy as possible, and also to get the process to work better than we thought it did before. A number of things. I mean, there are different systems between different directorates. In some cases, and particularly in CAMS, for example, there's a cut-off at 18. So we had a process that people didn't accept referrals into the adult service under 18, and therefore planning that meant that we weren't able to, or we didn't effectively transfer people over. It was a referral and a pickup and almost starting from scratch, as opposed to carrying over and a planned transfer of care with both clinicians and the comfortable handover from one to the other and doing things together. So that's what we were aiming to do. They have had a look at the policy. They brought a number of people in, including speaking to some service users. Our youth council were very heavily involved in this and gave us quite a lot of guidance as to what it was like to be a service user and what they were looking for and the sort of support they wanted. They have had a look at the processes and procedures around that. They tried to map their way through, and I think have done, in order to give people some guidance as to what we'd like, what we're trying to achieve, and to put something in that allows service users to move in a more seamless way, as opposed to potentially this referral and pickup. So they felt there was some continuation, and that there was a plan that they had, and they had some idea what to expect. I think it's done really well. There's more work to do, and not least in rolling it out now, because we've got the guidance there, we've got something for people to work towards, but it's very early days in terms of what people will see, and what we want to see is something different, so that when we go back and measure and we ask people for the experience they've had, it feels a bit more seamless than it previously has.
I've presented the work of the LiA team working on caseload management. So we've devised a new caseload management system that's going to be rolled out across all the community teams and the directorates. I think it was a recognition of the fact that caseload management A is really important, and B wasn't happening quite as systematically as we would like it to be at that particular time across the trust. So there were pockets of good practice, but we needed that to be more robust and systematic. So it's an important topic, really, I think, for the organisation, in terms of being able to give quality assurance around the work that clinicians and practitioners are doing. But paramount importance really is to make sure that we're providing safe, personalised, accessible, recovery-focused services to the clients that we work with, so mental health trust. I think one of the key challenges really is to devise a method of caseload management which suits the particular demands of all the different teams across the trust. So and not just the different teams, but also the different professional groups within the teams. So we're all on slightly different caseloads and we're on slightly different important challenges involved in the caseload. So to devise a tool that all teams could use was something that we wrestled with quite a lot in the early stages of the process. And our response to that really was to devise a core tool which had mandatory fields of information that would be gathered, but also that the tool is then customisable, so individual teams or individual practitioners within teams can then add information into the tool to make it suit their particular needs. The next important step, the remaining step really before the tool is rolled out, is to try and get some assurances that the tool that we're using will be digital friendly into the future. The particular concern in relation to that is that our current health information monitoring system, CHIPS, and or any future electronic patient record that we use should be able to theoretically or ideally be automatically populate the caseload tool. We're not quite at that stage yet. We're involved in some negotiations to try and establish whether that's going to be possible with the tool as we're currently developing. Once we're through that stage, then it will be rolled out and the teams will be using it and continue to audit it and review it and modify it into the future.
The presentation was about the Zokens. Now, Zokens is a staff stress tool, or more favourably known as a staff wellbeing thermometer or gauge, and it's actually a tool that we've set up. We've got 3 different versions. We have a paper version, a token version, and then an electronic version that we've piloted across sites throughout the trust. We've had 5 pilot sites who've used one of the 3 tools, and the idea is for staff to be able to highlight when they're having a stressful day, and it's a traffic light system, red, amber, green. And they will use one of those tools as an identifier to be able to identify when they've had the red day. Then the idea then is that the ward manager or team leader can go back in and reflect on the previous week to see which staff have had red days, which will then highlight the need for a conversation within that week. So the manager will then go back and have a look, have a conversation with staff, try and understand what the red was generated for, and work out if any additional support or intervention needs to go in to support staff. I think there's a uniqueness, although we've been doing it within the trust for some years now. We've been doing this since 2008 within some of the ward teams. People have started to recognise the real value of it and recognise that it was a really good process to be able to generate some support for staff proactively. To be perfectly honest, from an engagement point of view, teams are really taking it on. Teams and staff have said it was really good process, they've enjoyed being part of it, and I think it's the challenge about how we transform this as an easy use IT-based system for staff. But I do feel that we have been able to overcome some of them barriers now, probably a little later on in the process than we wanted to, but we've definitely got some commitment to take it forward. So the teams they've basically ran with it, they've used the tool, they've tested the tool. Some teams have actually changed the tool midway through, so people have gone from the paper version to the electronic version. Some teams have gone from the electronic version back to the paper version because they just felt that was easier. But what it's done is actually created that process. So it's created the process and it's created an opportunity for staff to have a conversation with the managers, and I think that's the beauty of it. It's such a simple thing, there's nothing complicated about it. We're going to have a super duper electronic version, and it's going to be a keypad on the wall that staff can actually just literally quickly record the staff stress level. From an individual point of view, we've got that data, we can capture it. From a ward point of view and team point of view, we've got it. But there's nothing stopping us from having a thermometer of let's see what the stress in the organisation is this week. So that's the way we want to go. We want it to be much bigger across the trust. But we've also got an application in to promote this beyond the trust. We're hoping to go and present at the National Health Service Awards, Health and Wellbeing, conference, which is in March time next year. So.
Our presentation is looking at where we were in terms of deaf awareness right at the beginning of the process, what we've done and what we're intending on doing in the future. With the deaf awareness, we were really keen to get partnership relationships with the deaf community in this area. So there's three main partnership areas, which are Deaf Links, Deaf Vibes and Assist, who manage and work with interpreters. And we were really keen to find out what the issues were for the deaf community. So our engagement exercises, we had three. We had a big conversation. We had a display at one of their events, and we were asking, what does a good health service look like? And really, what are your experiences from the deaf community in accessing health services? And we had just loads and loads and loads of problems with accessing and also solutions. So it was a win-win really, that they gave us the answers to the questions that we were asking. What we've done in the 20 weeks is we took what we needed to do as an organisation straight away, made those changes, and as time's gone on, we could just keep inviting communities back involved with us and charities back involved with us. It just means that you just have to keep going. And so that's been a challenge, is to convince people. They've probably been here before where people have promised we're going to do something and then it's drifted off. So it's just about keep getting them on board, convincing them that you are going to do something. One of the things that the deaf community told us that what would be an excellent service is if every single member could sign. And what we recognise in our trust is that although we've had pockets of excellence, we needed a trust-wide ability. So one of our goals is to train every single member of staff to be able to do the two-handed manual alphabet, and every single member of staff to be able to say, hello, my name is Sue. And so we've got over 350 so far trained in 6 weeks, and we're cascading that training out so everybody will be able to be trained. We have we've got hold of, and it's currently out there, 6 or 7 iPhones and an iPad, so that we can Skype and FaceTime, so that we can get onto an app to get an assigner there immediately, so that wherever the person comes in a referral, you can get that communication. So we took our 20 weeks, we've delivered on all of our goals in the 20 weeks, and Julia and the team, including our partnership workings, will go forward with the next lot of challenges for the next 20 weeks to move forward, and we will just keep it ongoing.
My presentation today was about the LiA team that had a mission to improve bed management across the trust, specifically for adult mental health services. I think that we recognise that the bed management process that we currently have was disjointed and a little bit complicated, and we knew that actually what we needed was a trust-wide response to improve bed management, its process, its function, how we do it, the way in which we do bed management. So by setting it up as an LiA team, we knew that with the philosophy of LiA to do the work within 20 weeks, we knew that we had a time-limited period to actually get some real good actions around bed management to improve the quality and the patient experience really for people who have to be admitted into our hospital wards. Some of the challenges that we found were around the interface between community teams and inpatient teams, and the bed manager and the bed functionality that currently exists within the access team. So you've got 3 large groups of staff who have all got an interest in bed management and are involved with the admission of people into hospital. So we had some quick wins. So one of the things that came out of our big conversation was that staff said, you know what, there's just too many meetings about bed management. There's 3, 4, 5 meetings a week, and we haven't got all the right people in the room and having the right conversations. So we just decided to have one meeting once a week where all the right people were there to really understand bed pressures and bed management. I think that because the mission statement for bed management was so huge, it was just to improve bed management, we could have done this for another 20 weeks and another 20 weeks and another 20 weeks. So what we did say fairly early on in the process is that we really had to just concentrate on the adult mental health wards. So I think a real challenge for us is to say, you know what, it isn't just about adult mental health, it does include our partners, because we've all got an interest in bed management, we've all got an interest in that process being as fluid as it can be, and actually we all want the same thing, we all just want the experience to be better for people that have to come into hospital. So the next steps are we are going to launch our nurse practitioners working 7 days a week, which is a big change for us, and that just means it doesn't really make any difference whether you're in hospital on a Saturday or whether it's a Wednesday, that you can expect the same sort of service. We are going to work with our colleagues to actually put pathways in when we do have admissions for children and when we have admissions for older people. We want to progress the gatekeeping and readmission challenges that we've got. So we want to make better offers for people so that they don't find themselves being readmitted into hospital beds. So there's lots still to do and lots still to work on, but I think what we've achieved allows us to come from a place of more stability, that we've got more process guidance and understanding, and now we can do some of the more difficult things that we need to do around bed management.
I believe it came out of some big LIA conversations where staff got together to discuss various issues and barriers, and it became a theme and a pattern that the trust values needed to be reviewed. The challenges that exist really are the fact that staff have got at the moment quite a negative culture about them, and I think that's because the values that we've got from our consultation has been about them being too wordy, too jargonistic, so people can't remember them. And the argument from staff is if we can't remember what the values are, then how on earth can we embed them in our everyday practice to support good quality care for our patients? What we've been doing at the moment is rather a large consultation. The Trust want us to do a huge consultation, not only with our staff, but our service users as well. Very much from the bottom up is the approach that we're using. So we've done SurveyMonkey, we've done face-to-face events, we've done face-to-face on tour rather than bring staff into the Trust to have a conversation. We've gone out to them. So we've tried to do it very informally to try and get messages that the staff are trying to tell us in terms of what behaviours they want to see and what they expect in their new values before we then move on to create some values. I think we're very much engaging with staff at the moment and listening to what they're saying. We've probably done about 450 to 500 face-to-face consultations with our staff now, so I think we've done quite a heavy consultation process. The next step for us is to do a big LIA conversation with our service users, and then from that we will start to theme what's coming out from where the staff are asking us to do things and look at things, and then start to produce documentation. We want to share some good role modelling, so it's more visual, so our staff start to feel recognised and valued for some of the behaviours I do feel that they already have in place. The next steps for us is this service user consultation, just a little bit more in our clinical areas in terms of consultation I feel, and then it's to get a group of staff that are willing to work on this together again, to start to theme and find a pattern that we can then start to create some acronyms and different acronyms of values, which is very much what our staff are asking us to do, make them short, snappy, simple, easy to remember. And then we'll look at how we start to embed this into our everyday practice through one-to-one meetings, team meetings, asking teams to share good practices on how they are meeting the values and behaviours of the Trust so that others can learn from that.
Our presentation was about sharing what we can do and how we can take more ownership around our working environments, mainly, for the benefit of our patients, carers and staff that work in there. And what we were trying to showcase is it's not always the big things, it's the little simple things that can make real big differences to how people feel within their environment. And I think the other thing was to try and get the message across that how LiA can be used to unblock some of the blockages and get things kind of moving, and how LiA, we can use LiA to involve patients, service users, carers and staff. Some of the challenges were around blockages, changing of rooms, changes of function, usually when things have either got difficult or people have challenged why, or there shouldn't be any changes. It's just been left at that and not sort of pushed further as to the block, that blockage isn't good enough really. We need, it's for the benefit of the patients, it's what the patients want. So asking for some further clarity and explanation as to why that blockage can't be unblocked. For inpatient environments, we've changed the function of a few rooms on one of the wards to make the admission when a patient's first contact with the ward, to make that room comfortable, friendly, welcoming. We've made one of the clinical rooms professional, sort of where patients go for physical examination. It now looks professional. It looks, sort of well equipped, which gives patients reassurance. We've looked at kind of rooms that are suitable for our patient group. So lots of reminiscent rooms, sensory rooms that we've put in place. I think the team have kind of come together as a group really, and sort of asked for more explanation of the challenges and utilised each other. They definitely utilised our LiA sponsor group and utilised the exec team for support and driving that change forward. The next steps, we've got a change in culture. We've got quite a few staff now coming forward that want to make it either more changes, or there's another ward that's wanting to use our LiA. So what we'll be doing is just continuing to embed, but hopefully spreading to other areas as well.
I think as a group of junior doctors, we work in lots of different parts of the hospital in lots of different settings. And I think historically, while we are quite cohesive as a group and work well together, I think sometimes there is the feeling that because we are spread out across the trust, sometimes we get missed almost in terms of sort of, organisational things that are occurring. So I think really it was to try and, as a group, get everybody engaged and sort of working together to really pull out any changes that could be made, any improvements that we could sort of look at with regards to our practice and our work within the trust. More than anything, we are quite dispersed and we do work in quite a wide range of clinical areas, so there are lots of differences with regards to teams and sort of how individual doctors' teams are structured. So that was a challenge in terms of actually working out what somebody else's team does well, what your team could do differently, and sort of how all that fits together really. And we decided as part of the listening interaction and sort of moving forward, we've decided to incorporate the listening interaction framework as part of our Junior Doctor Forum, which occurs every quarter, to try and sort of keep the momentum going, because we have quite a fast turnover of doctors. Sometimes they're only with us within the trust for 4 months. And people, as I say, do sometimes get missed. So to try and keep the theme going as we move forward, we're incorporating into that, so hopefully as many juniors as possible will be involved in the process. Well, we identified a number of quick wins and then sort of more long-term goals. So the quick wins have been things like increasing amounts of information within the Junior Doctor Handbook that's provided at the induction. So making sure that people know how to access the access team and the team at the Royal Stoke Hospital. We've also done a lot of work with the nursing staff within the trust regarding physical health, particularly since Ward 4 has been set up and obviously the shared care with the Royal Stoke. Just really to increase the skills of our psychiatric nursing teams with regards to that, so that we're all working more as a team to manage patients better. We met as a group and the attendance was really good, and people were very willing and very keen to get involved with things. So there was a cohort of juniors who split off to do some of the physical health work. With regards to the more simple stuff, at every Junior Doctor Forum now, the listening interaction is incorporated, so if there are any issues or any problems that are identified, we're adopting that framework to see what we can sort out very quickly, and if something needs work, then to take it forward and make sure it's followed up.
LiA identified the support worker group because the support workers didn't feel as if they'd been listened to through in the trust. that they needed to have a voice within the trust and to be kept updated about what was happening both within the trust and within LiA. So that's where we identified them. And in level 1, in wave 1, they weren't really involved. None of the STRs, healthcares or the activity workers came forward. But in wave 2, because they had their own group, quite a lot of them have come forward to take part in that and to be part of the ongoing process, and we're now embedding it within the trust. So we're having meetings and forums every 2 months, which they're invited to. They can bring ideas forward, they bring their quick wins that they've done over the last 2 months, and then we embed it with other care workers that are coming to the group. We've had several quick wins. The blue badges for Ward 6, that's been spread across a couple more areas now, so we're just waiting for those badges to come. Car parking for the A&T Telford, which is the disability unit. Cars were parking over the ramps and things like that, so we've had that notified and people are asked to move immediately as soon as they park there now. We've upset the forum up so they do have their say and they can come along with those ideas, so that's been set up through this group. They've got a lot more say, they feel a lot more respected and valued within the trust. So that's some of the things that we've done. We're looking at other projects at the moment about a zebra crossing up at the top of the road, at the top of the Harpens. So when it's healthcare support workers, activity workers want to take service users out, they won't have to walk all the way up to A&E to cross the road. We'll hopefully get a crossing at the top of the Harpens. I think we've met the challenges head on. I think everything that comes to us we try to address. We've got healthcare workers working on things at the moment that are still challenging us. It's about breaking the boundaries down, and we're working very hard at breaking the boundaries between staff that are higher up the levels and the healthcare support workers and STRs and the activity workers. And with that, I'm one of the leads that breaks those boundaries down. I'll go and speak to the people I need to speak to, whether it's the ward manager, whether it's the chief exec, and trying to break those barriers down, because we don't want barriers to hold our staff back. We want them to be able to get on with the job and have no barriers to what they need to do, so the job's easier for them. We're going to carry on with the forum. That's going to continue. That's not going to go away now we've started it. We're trying to get more people involved, so the healthcares and STRs and activity workers that are involved in that forum at the moment take things back to their teams every time the meeting's held and bring things back to the forum. We're just going to try and embed it throughout the whole trust, whether it's at the Harpens or in the community. We need to get involved with all the STRs, healthcare support workers and activity workers in the trust. So the more we do, the more we hope we'll get on board and make a bigger forum.
From the work that we'd done in Wave 1, it was apparent that we'd done some of the quick wins, and there were other issues that we felt we could address that still needed to be progressed. So with that in mind, these were longer term processes. So some of the things like getting a new occupational health provider, you can't do that as a quick win. So it was necessary for some things to roll over into a second phase. I suppose the big problem was that the quick wins were delivered quickly, and that was the issue. The longer term things were more complex and involved cultural change as much as they did changes to systems that could be done very, very quickly. So one of the objectives in the NHS as a whole is to move towards values-based recruitment, for example, and that involves a major cultural change in stepping away from where people feel comfortable as interviewers asking questions of candidates in the more traditional sense, getting them to move away from that into values-based questioning and asking people how they feel about certain situations. How do you deal with this scenario? What are your values? What's important to you? And how does that dovetail with our goals? Those are difficult questions to ask. They're difficult. That's a difficult interview scenario to run, and it takes time for that to be embedded for managers to feel comfortable in doing that. We've changed how we recruit, and we've trailblazed something new in the organisation that we've not really done before. And in the last 6 months, we've really pushed recruitment in in a non-standard way. So we've gone to Signal Radio, and we've had one of our experienced nurses from Ward 1 be interviewed on Signal Radio to try and get the word out there, to try and get our advertisement, our vacancies out to a different audience. So people who are looking for work will go to NHS Jobs. And then when we've got them in and interviewed them, we've done a one-stop recruitment, which is where they're interviewed, and on the same day they have their identity checked for all their ID checks and for their criminal records disclosure, the DBS, and they've had their occupational health check done on the same day. So it's all trying to condense it all down into a single day and get people into the organisation a lot quicker. The team have put together a list of these value-based questions, and they're mapping those now to the leadership framework that the board are working to, and the board assurance framework, to make sure that the questions that we're asking are dovetailing with the organisational values. So now they're starting to cross-link with other LiA teams and engage with them, so that we're all kind of moving forward in a synergistic way. So we want to have some kind of less formal method of assessing staff for their suitability for the role, against their values, against the organisational values, but without having it perhaps have a one-on-one traditional interview setting, which can be quite intimidating for people and may not actually yield the most useful information about that person's suitability.
Our team was one of the first wave projects, and we did lots of work in the first 20 weeks and came to the last Pass It On event to pass it on, and we got it back. So we're back again. We felt that we'd done lots of work around what our preferred approach was, but it wasn't embedded. So what we wanted to do was make it normal practice for how you do things. And that's been the key focus of the last 20 weeks, really, is trying to make this approach that everybody knows about, so staff know what our particular approach to change is that they should expect and what that means for them, and that managers that need to implement change in their teams, they know there's an expectation on them to follow that approach and get staff involved. Staff was saying that there's such a lot of change, and we feel change is being done to us rather than being able to shape change themselves. So that's the key change that we're trying to make. Staff have a voice right from the beginning of the process, and they're able to work things out themselves. We were a trust-wide project. That was a big challenge, but because we'd already had 20 weeks, to come back and have a further 20 weeks and keep people motivated, and there's quite a high pace with listening to actions. We keep meeting every 2 weeks, making changes and reporting progress so frequently. Staff side were fantastic. They've supported right through that process as well and worked with us on this. Our slogan for the project has been "No change without me," which is taken from the patient approach. Nothing about me without me. So we want the same for staff, really, that change doesn't happen without staff having that discussion. We've got lots of resources for staff telling them this is the way you do it, this is what you'll experience, this is how it might feel, information about the change cycle, so you know the sorts of emotions that you might experience and how they go up and down as you go through that process. Telling you that your manager should do this engagement approach and who to go to if they're not, so you can challenge that. So resources for staff, a resource for managers as well to support them to do that approach, so they've got sort of toolkit to help them to do that. We're launching a new texting support service for any staff as well, staff and managers, and we're going to recommend that for staff who are going through changes as well. That might be time to use that. You sign up for a couple of months. It's a system called Flow, so Flow sends you messages. You can adjust the frequency of how often you get those. People have been really good, got on board, people with lots of experience of change, and particularly staff side, and managers and staff from across the organisation, people who've got lived experience of either supporting people through that process or people who've actually been through processes and been affected by them as well, saying how to help for them as individuals. And that's been one of the key things that we're trying to do, is to make the process as human as possible.